All right. Hello, everybody. Let me welcome you to our webinar session today. That is all about clinical cases in fetal cardiac MRI. We will learn about 5 clinical cases from 5 different sites. Short note that this webinar will be recorded. It's myself, Heide Böth, and Fabian Cording that will lead you through this session today again, like also during the last session. And we are very happy to meet you all or to see you all again. And just a short reminder here that this session today is a spring session, and there will be 3 more sessions this year. It will be the summer, the autumn, and the winter session that will follow. So be aware of that. It's only the first one in spring, and we had a kickoff session at the beginning of this year, and this was recorded as well and is also online available for you in case you have missed it. The aim of our webinar is to build a community and to offer a platform for networking and exchange. And this is actually quite important for us. That's why we have, or this is what we have also shown in our magazine that we have just recently been published. And this magazine gives you an overview of the latest insights from the world of fetal cardiac MRI. And you can download this magazine on our homepage. Yeah, as our agenda is again quite tight today. I wanted to say each participant can talk and discuss with us, and we are happy about this. We want a discussion. This is exactly what we aim for. If you want to talk, raise your finger to show us that you want to speak, and then we will allow you to do so. If you have questions, please paste your questions directly into the chat. And you can also use the Q&A function that you will find at the top bar of this meeting. And now my last sentence, as our agenda is quite tight today, and in case we need more time for the discussion, we have the possibility to add a few minutes after the official end, if this is desired. Then just give us a short note in the chat, and then we can extend the session for a few of you if you want. Also, for you as information that we have just recently created a fetal CMR guideline that you can also find on our homepage, or you can also send me an email if you are interested, and I can forward this to you. In this guideline, we have summarized feedback from over 60 customer sites worldwide, and we want to share with you, or this is the aim, to share tips and tricks for implementing SmartSync, and also to aid with sequence planning and adaptation. So we have this 3 sections here in this guideline, and are happy to share this document with you. It's for sure very helpful. And now I quickly hand over to Fabian.
Hi everyone, great to have you here as well. Short news for everyone. We now have also a new application for adult and pediatric cardiac gating. We have a short video how it actually works, so you can see it here. So it's very easy. You just use the same transducer, the device that you probably already have, if you have it, of course, and then you can use it for pediatric as well as cardiac gating. This is available with the new software version. Everyone can access it, and you just get a trigger which is close to the R wave, about 100 milliseconds after it. And we think that can be really nice for pediatric applications because there are no electrodes, and it's also quite stable if you have patients that are post-surgery with scars. So don't be afraid to use it. It is CE labeled, and we all encourage you to use this and to evaluate it. And we of course have also done this, and these results are quite nice. The slides are gone.
Okay. Okay, we are back. Some technical problems.
So yeah, please reach out to us if you have questions about this. It should be available for everyone now.
Great. And now let's jump to the most important thing today, our experts, and we have 5 of those. Actually, sorry, there's one image missing of Christopher, but you will see him later. So we start today with Mansi Gaitonde from the University of Texas, Southwestern Medical Center in Dallas. And Mansi, great that you are here. I will directly hand over now to you, and please feel free to share your screen.
Okay, can you see my screen well? Let me move these things over.
Yes, you can see it. Great.
Coming on the screen for some reason. Can you see this thing up here? I'm just going to ignore it, so I'm sorry. All right, so I'm Mansi Gaitonde. I'm one of the pediatric cardiologists at UT Southwestern in Dallas, Texas. So I'm going to go through this case on fetal aortopulmonary window. The reason I picked this case was not because the images are pretty. In fact, Heidi encouraged us to show some things that were challenging, but because I felt like we still had made a clinical impact despite how difficult this was. So we're about 2.5 years into building our fetal CMR program. So we've transitioned from research-only scans to billing for clinical scans in the past 6 months. The team consists of me and one of my colleagues who's another dual-trained fetal cardiologist, and then we have 2 fetal radiologists, a physicist. And when we started this program, our MR techs had already come in with some experience imaging pregnant women, but I do think that's very important. And we have a nurse who's dedicated to our cardiac MRI scanner. She helps mothers as well when they're coming in. And then finally, we do have our scheduler who's dedicated to our MRI scheduling. And that really helps, at least in the United States, when it comes to issues with insurance and billing. Our scheduler facilitates all of that ahead of time so we can get our scans covered. We're doing them in the late 3rd trimester for our clinical scans. Our magnet is a Phillips 1.5 Tesla magnet, and we have a big bore, so that's comfortable for the mothers. We're not using any sedation, and we are utilizing maternal breath holding if possible. And the SmartSync device, which they reviewed. Our techs are the ones auscultating for placement. So I'll go into the case. This all started with my fetal fellow who went over to our county hospital with the maternal fetal medicine clinic and was there doing a rotation, and she came back in the afternoon and said, I think we found an aortopulmonary window on this fetus, which I thought was really unusual because I've never diagnosed that prenatally. But fortunately, they made an official referral to our fetal heart center. So they always come in through our heart center. And so we start with the fetal echo. This was around 30 weeks due to the suspected CHD. There were some spinal defects that were maybe suggested and diabetes in the mother. So the screening fetal echo definitely looked convincing. So we patted her on the back, said, okay, this really does look like an aortopulmonary window. In addition, the aortic valve appeared a little hypoplastic. We could not really see the aortic arch, but otherwise the fetus appeared well. So our fetal center does consist of a multidisciplinary team that includes consultations with other services. And so we involved the NICU team, social worker, psychologist, maternal fetal medicine obviously was involved. And we can also include our CT surgery team, cath, palliative care, genetics, et cetera, whatever is needed. And it was deemed that this patient would benefit from a clinical fetal CMR scan. So we did this around 33 weeks, 3 days gestation. Interestingly, a few days before the scan, so we'd already gotten it approved by insurance and set up, the MFM reached out to us and said, we're worried about the placenta accreta spectrum, and maybe we need to just, do more of a focused body fetal MRI. But we worked with our radiologists who, are very experienced in imaging the placenta, and we're able to make sure that we were able to get the right sequences at the time of our cardiac scan. So there were 2 kind of important questions in addition to the cardiac findings, but also imaging the placenta. And I think we can be proud of the fact that we got through it all, considering how challenging this scan was. This is our typical exam card. Our radiologists do like to have these survey slices from the maternal perineum to the liver so that they can just do, it gives kind of a good overview of all the fetus organs. And when we're kind of dedicated to the cardiac scan, we do want to make sure we're not missing anything that's a major extracardiac anomaly. So this is kind of their survey. And then we're using the SmartSync device for our Cine imaging, and then there's a combination of T1 and T2 weighted black blood stacks that we get, and I'll show you some of the stuff that we had gotten. And sometimes it's necessary to do dedicated lung imaging if we're really looking for lymphangiectasia and findings of nutmeg lung. We'll add that on. Brain, placenta, and 4D flow has been an intermittent success for us. So obviously in late pregnancy, the mom can get uncomfortable, and then fetal movement can make the scan very stressful. So I'll show you our images here. Hopefully this is showing up for you well. So this is our initial survey image that I talked about for the radiologist. So it starts all the way at the perineum, and then they get a good look at most of the organs here and to make sure there's no problems with the kidneys, lungs, brain, etc. So we tried to start off with some Cine imaging, but you can see here that, you know, we're in the area where we're in the outflow tracts, but these images, the baby was just moving so much that this was really not diagnostic at this moment in time. We spent a little more time trying to focus on some black blood imaging, but this was all very blurry and very difficult because the fetus was decided that he did not want to be still at all. So we took a pause, took some deep breaths, and spent some time looking at the placenta a bit. So took a little bit of a break. And our conclusion at that was that the placenta accreta was not clinically significant. And so I felt like we got very good images from that regard. We came back to the cardiac images, and again, we're trying to work on getting some black blood stacks, which I feel like if you're looking in this area and trying to diagnose much, I think we can see a ductal arch, but beyond that, not very clear that there's a definitive aortic arch here. Our best pictures eventually were through our Cine images, and you can see here that you have a good size right ventricle, a tricuspid valve, some probable mild right atrial dilation. You start to get the left ventricle into view. It does look like it's apex forming, and then a good sized mitral valve. You can see some pulmonary veins coming into view, and the LV outflow tract did appear open. As we're coming more superiorly, you start to see the pulmonary outflow, and here is where we're expecting the aortopulmonary window to come into view, and there's a deficiency in the septum, in this wall here between the aorta and the pulmonary artery, and this was the location in which the aortopulmonary window was located, and it's quite big. The other question was, you know, how is there an aortic arch present? So we're continuing to look to the back of the baby, so the posterior part. We have a descending aorta here, trying to figure out if we can define a transverse arch located here. You see the SVC and an innominate vein. You have a ductal arch here. And if this is the aortic arch, we suspected that this was very small. And so a significant obstruction was suspected based on these pictures. So that did end up changing our plan for the baby. So postnatally, the baby was started on a prostaglandin infusion due to suspected severe arch obstruction. The baby had a routine repeat C-section, and there was no placenta accreta identified. So we made a good call in those regards. And the baby came over to our cardiac ICU after birth in good condition. Unfortunately, I don't have like a nice reconstruction of our fetal images, obviously, because you saw the quality of those, which was the black blood imaging was probably not the best, just due to the baby moving so much. But this is our postnatal CT, and you do see the large aortopulmonary window in the region that we described, and then it actually ended up being a type A interruption. But the baby's doing very well, underwent surgical repair, and was discharged within a week and a half after surgery. So from what I've learned so far doing this, obviously we are we're a center that is working on building this, and there are definitely centers who are further along in their process, and we look to them to get a lot of expertise and questions answered whenever we're having trouble. But one thing that I feel very strongly about is that the fetal motion is going to be a problem, and so especially when you're doing clinical scans and there's directed questions that you need to be answering, you're obligated to be able to answer those well. So from our standpoint, we're hoping to transition towards more deep learning methods for reconstruction of these data sets. That does take a lot of investment, and you have to kind of take a plunge if you've never done this before. So it is a bit of anxiety around that, but I think that is really the way to go. And then I think there are some other centers who have also taken some very innovative techniques in terms of imaging, the cine imaging, and not relying on utilizing slices in the fetus, but imaging more of the heart as a whole. And that may also be something for the future that can eliminate our worries about the fetus moving in and out of the planes that we need. So I just want to thank my team. And obviously, if you have any questions, you can reach out to me. But I definitely recommend utilizing the community that we have because everyone here is so willing to share their knowledge. Thank you.
Thank you so much, Mansi, for this insight. There is a question for you that we directly want to raise. Can you give, Mansi, a little bit more details on the sequence parameters, like slice thickness, field of view, number of phases? You have to, you are muted. Mansi, you are muted, yeah.
Yeah, I'm happy to send that over. Is this, yeah, so we do obviously try to get a smaller slice thickness, but, and I'm happy to send over like our exam card. If you like CC me your email, I can send you what we have. But again, like when we're using our sort of standard balanced SFP images, a lot of the problems are still just the fetus moving. And so I think that you have to be really careful about like making sure that your area that you're trying to image, and when you have a clinical question, sometimes you have to change how, like where you're starting, where you're finishing. And I think we have to like be a little cognizant of the future in terms of maybe we do need to focus more on imaging the whole heart, because I do think this has been a problem. We think we're getting the right slices and the baby moves, and so that's been a little bit of a challenge, I think. But I'm happy to send over our exam card if you just CC me your email. That'll probably be easier. So.
Great.
Okay, perfect. Thank you, Mansi.
Thank you.
Thanks so much. I think it's a great case.
All right. We will now jump to our next speaker, our next expert, which is Gloria from University Clinics München. And currently, Gloria is Gloria is working at Hospital Necker Enfant Malade in Paris. And Gloria, great that you are here. I will now hand over to you directly. And you already shared.
With pleasure.
And we can see the slices. Yeah, great.
Can you see? Oh, perfect. Thank you, Heidi, for this very nice introduction. As you already said, hi, I'm Gloria. I'm from LMU University Hospital in Munich, and I'm currently doing a research stay in Hospital Necker Enfant in Paris, which is in France. I will give you a short overview of what I'm going to talk. I will start with my CMR experience and then give the clinical background of our presented case, which is followed by the case presentation and some further clinical course. I saw my first very impressive fetal CMR in June 2022. Since then, I have seen about 40 cases, 22 of them here in Paris, and they are predominantly heart and lung malformations. And I will have you a quick look at our protocol, which is a GE Signa HDXT with 1.5 Tesla. We always start with maternal sequences with axial, coronal, and sagittal orientation, which is then followed by the fetal heart, which we try to make immediately, because after that, the fetus tends to be quite calm because they are in apnea, in breath hold. And then we go on with the protocol that is following, which includes heart and body sequences. So our case is a 30-year-old mother and a 38-year-old father having their first pregnancy, which was conceived by an in vitro fertilization. The mother has a BRCA1 mutation and has undergone appendectomy and thyroidectomy. So medication consists of levothyroxine and timeferol. No pregnancy complications were known, but in the medical family history, the father had a little bit of an augmented cranial perimeter at birth, so he had a mild hydrocephaly, which was all. And they were referred to as center due to a dilatation of the lateral ventricles and an intracardiac mass of the left ventricle at the 3rd trimester ultrasound, which was conducted at 33 weeks. So the diagnostic echosonographic findings at the first ultrasound that was conducted at our hospital at 34 weeks was a cephalic presentation of a little boy with a fetal macrosomy with an estimated weight above the 99th percentile, a fetal ventriculomegaly, mostly unilateral and left-sided, with 16 millimeters, a fetal organomegaly with an augmented renal volume and a hepatomegaly, and last but not least, the intracardiac mass, which presented ISO until hyperechogenic and attached to the lateral septal wall of the left ventricle, disturbing admission and ejection, the aortic arch with no clear narrowing to that date, and also no retrograde flow in the ascending aorta. And this was to be controlled by a pediatric cardiologist. Afterwards, apart from that, the patient refused amniocentesis, but blood testing did not reveal a trisomy positivity in a blood test. So I would like to show you the cardiac ultrasound examination that actually took place under very difficult conditions. And the problem was that we had a quite unfavorable fetal position with its back ventrally here and in a cephalic position. So in ultrasound, we had lots and lots of artifacts from the spine and the bones due to that already very late gestation. So we let the pregnant woman turn from one side to the other and to the first once again to get the best possible position to perform the ultrasound and to make the fetus maybe turn a little bit. And this was already a little better. So you can see the thickened myocard walls here of the left ventricle, but already not perfect. And then, oh, I'm sorry. I hope this works. Yeah. Then we have caught, I think, quite a good moment here. What we could state was the appearance of a heterogeneous tumor dependent on the left ventricle here, appearing to encompass the inflow and outflow zone, and thus limiting filling and ejection of the left ventricle. And the aorta, which is not to be seen here, appeared to be fed retrogradely by the arterial duct. So you can see there are zones with hyperechogenic and isoechogenic signal intensity here, and the mass measured, I think, 2.5 x 2.5 centimeters. Yeah. In the ultrasound, there was a little flow signal detectable in the left ventricle here, although the mass occupies almost the entire ventricular cavity. But in this image and afterwards, the artifact got worse again. So we finished the examination, the ultrasound examination, and clinical indication for MRI in order to assess associated malformation was already given. So as ultrasound conditions were difficult, we decided to add some cardiac sequences. Clinical MRI was conducted first, and the images were mostly insuspicious apart from the already known ventricular mass. In particular, no brainstem or cerebellar anomalies were to be seen, but in the supratentorial region, we saw a tiny subependymal nodule, and this was not the only one that were observed compatible with heterotopic nodules. The lateral ventricles were enlarged in the posterior portion, particularly in the bitemporal regions, but we saw no anomalies of the germinal zones, gyration, or the sylvian valleys. And at the thoraco-abdominal pelvic level, we confirmed the hepatomegaly, which is here. This is the liver. But with normal signal, and the kidneys measured 47 millimeters, which is quite long. So the kidneys were a little too big, but with normal location and normal morphology. After performing the clinical MRI sequences, We had a first attempt for a 2-chamber view. After that, 3 attempts for a short axis and 4 attempts for a 4-chamber view, which unfortunately all had major artifacts. So we went into a second round and then got some acceptable sequences of a 2- and 4-chamber view and a short axis, which I would like to present now. And still, the images are far away from perfect. So this is not our best case, but I think a very interesting one. First, some static images. Cardiac MRI showed a large left ventricular mass at the basis of the left cavity, which you can see here, here, and here, with a quite homogeneous internal signal positioned analogously to the ultrasound description. So we're going to start. Unfortunately, our PACS stations don't have a microphone nor a camera, so I have some downloaded videos which have a little worse quality than in the PACS, but I hope you can see anyways. The mass is appearing here with some blood, which is passing besides or above the mass. I'm going to wait until it shows up once again. The mass is here at the basis of the left ventricle. After that, same in a short axis. We do have artifacts, and we do have some double contours of the maternal abdomen here, originating from movements in a time in which the pregnant woman should have actually not have breathed. I think this is quite a good slice here. And we're going to go on with the 4-chamber view. In which you can see quite some of double contours of the abdominal walls, which is caused by bereavement artifacts of the mother. And apart from that, we noticed a generalized hypokinesia of the left ventricle compared to the right side. This part is not really contracting, whereas the right side shows good contractations. What I think also caused some of our signal problems, but we can discuss this later. So, in the following, I would like to show you some of our failed tries, as Heidi encouraged us to do so. This sequence started good with quite of movement artifacts at the end. The next sequence already started with movement artifacts or with bereavement artifacts here and got worse and worse. And also a 4-chamber view, which showed the mass that had quite some artifacts concerning the big vessels. So, after the weekend and at the day of the MRI, the first ultrasound was performed on a Thursday, and then the MRI and the second ultrasound on the Monday. So ultrasound was repeated and confirmed an voluminous iso until hyperechogenic tumor of the left ventricle, limiting opening kinetics of the valve and considerably reducing the ejection pathway. Only the right ventricle revealed satisfactory systolic function, what we already assumed after the MRI, and mitral aortic continuity was difficult to see due to the bulky tumor. We saw no septal aortic shift or septal defect, and recently a small pericardial effusion lamina appeared. Concerning the large vessels, the size of the pulmonary arteries and the aorta was described within normal limits, but the aortic arch appears complete, but was located to the left of the trachea, which cannot be seen in this image here, but which can be assumed because here we have the vertebral columns. So the trachea has to be just ventrally, and the aorta is passing on the left side. Pulmonary bifurcation with pulmonary branches were of normal size and course. So trachea speed and mitral flows were normal with no significant leakage here. The mitral valve is shown exemplarily, and apart from that, we saw a retrograde flow of the arterial duct. To sum up, this confirmed the recent data of the voluminous left ventricular tumor that was to be seen, limiting mitral opening kinematics and considerably reducing the ejection pathway with a retrograde flow of the arterial duct and a small lamina of pericardic effusion. However, we in the MRI saw a homogeneous mass, while the signal in ultrasound was clearly heterogeneous. And so I would like to let this be followed by a little excursion of cardiac masses. In general, fetal cardiac tumors are very rare conditions, and their incidence ranges from 0.08 to 0.2%. And the three most common types in fetuses, newborn, and children are firstly rhabdomyomas, and then teratomas and fibromas. So rhabdomyomas are the most common, and they present homogeneous hyperechogenic masses that are often multiple with various sizes. They may be intramural or intracavitary and generally occupy the interventricular septum or the right ventricle, are close to the moderator band. And rhabdomyomas are hormone-dependent tumors, which explains their well-known capacity for spontaneous regression or reduction, along with a close relationship with tuberous sclerosis. And if you remember, we saw those little subependymal nodules in the brain MRI. The image here shows multiple bright hyperechogenic pseudotumoral lesions, for example, here, within the myocardium, intraventricular septum, and the atriums, which I think resembles our case the most, but we'll discuss this just later. In contrast, teratomas are generally present as extracardiac masses, which are located close to the aorta or the pulmonary arteries. They have a rather multicystic formation, and they may evolve with a pericardic effusion, which we saw, but the rest does not fit to our case. And last but not least, fibromas are very present during fetal life, but are generally located in the interventricular septum or at the free wall of the left ventricle, which is exactly the position of our mass. They present as large single masses, which is also the case in our case. And differently from rhabdomyomas, they do not regress after birth. For this reason, they may cause obstructions. So following ultrasound examinations, the heart mass did not resemble a rhabdomyoma because in ultrasound it was hetero. It had a heterogenetic signal, and the cardiopediatrician assumed a teratoma. But following the MRI, it was homogeneous, and I think it resembled a rhabdomyoma. So fitting to the subependymal nodules, it makes the diagnosis of a tuberous sclerosis quite probable. Alternative diagnoses were a hypergrowth syndrome or just polyformative disease or syndrome. And together with the couple, the birth was organized with cardiologists present in the delivery room and a cesarean section for the best possible neonatal and obstetric care. Unfortunately, the infant was born and passed away in the delivery room just 40 minutes after birth, despite an instant reanimation, and a pathologic examination followed, and it macroscopically showed cardiomegaly with a white pearly mass, which you can see here, developing at the posterior and septal wall of the left ventricle, a very small remaining left ventricular cavity, which is just this part of the heart, remaining and the absence of trabeculations. The fetopath, the fetopathologist, saw a bicuspid aortic valve, and I would like to have solved this case today. And I checked of new examinations uploaded to the case maybe 10 times, but unfortunately, I am very sorry. We don't have a histologic examination present now. And we assume that is either a mass in the context of tuberous sclerosis or a polyformative syndrome. And it stays unresolved. I'm very sorry for that. So I thank you thanks for your attention. Thank you for listening. And I'm very happy to answer some questions. And again, I am really sorry that we can't solve this today.
No worries, Gloria. Thank you very much for this case presentation. Maybe you can solve it later when you have the result in the next webinar session.
Yeah,
or something.
avec plaisir.
Okay. And just a short addition, because you have shown images where you said, or videos where you said it's not the best image quality, and I would like to mention that that was also the idea behind this webinar session today. Like Nancy,
yeah, exactly.
we don't want only to show the best images, like it's sometimes the case when you present in a webinar. We want to show today the reality, so what is really also the challenges, and so this is also the idea behind it. So you see the real scan from the beginning to the end, and also including challenges. Just
thank you for making this point. Maybe I should also mention that the clinical part of the MRI already had a duration of about 40-45 minutes. And then we just started with the heart sequences and installed the transducer and all that. And at this point, the woman was already about 50 minutes into the machine. So I think it is a little evident that it were not the perfect sequences, and she was not able to perfectly hold her breath. And I think this is quite understandable.
Mm-hmm. So there are some, thank you, Gloria. There are some questions now, just from Sally and Kerr, but we have to be quick. Another minute, then we need to change the speaker. Retrograde flow in the aorta, not in the ductus. Surely, that was the question from Sally Ann.
No, there was a flow in the aorta, but we saw retrograde filling on top of the filling of the aorta by the arterial duct.
Mm-hmm. All right.
Okay.
And then there's also another one. Did you consider treating with sirolimus?
In the assumption that it is rhabdomyoma, but we were not sure. And at this time point, the fetal MRI is very new to that side. It is just me who brought it up maybe 6 months ago. And at this time point, we are rather in a research context than in a clinical context. So no, they trusted the ultrasound, which was quite sure that it is not a rhabdomyoma because of the signal. So they did not consider treatment with sirolimus, no.
Okay. Great. So there are a few more questions, but we have to move on. So maybe
I'm sorry.
Can answer them in the chat, or the people interested stay longer in this meeting, and then we can talk after.
Of course.
After the meeting. All right. So we continue, and Peace. Now it's you. I'm very happy to have you here, Peace Madume from Nemours Children's Hospital, Orlando, and yeah, I'm happy to listen to you, or we are happy to listen to you. And I can see your slides well, so.
Perfect. Thank you, Heide. And Heide and Fabian, thank you very much for allowing me to present this case. And I also want to just thank you for the collegiality that you guys show. Obviously, we're using your product, but you guys are demonstrating great collegiality and collaboration, especially with sessions like this. It's very much needed within our field. So my name is Peace Madume. I'm the Director of Advanced Cardiac Imaging at Nemours Children's Health in Orlando. I'm going to present a case of that I call the upside down heart, and hopefully I should be able to go through this fairly quickly. In the interest of time, I have no disclosures. From a fetal cardiac MRI history standpoint, we started in May of 2023. We've done about 5 scans with dedicated cardiac imaging, but that imaging was at the tail end of a regular fetal MRI scan. So all our scans are cardiac scan add-ons to fetal MRI scans, which I believe are what most people are doing. I'd be interested to hear if anyone is doing just specific fetal cardiac MRI scanning, especially in the US, and if they're able to bill for that. Obviously, the challenge is the length of the scan when you're tacking it onto a fetal MRI scan, as was just mentioned. The case that I'm going to present is a 21-year-old first-time mother with a 31-week fetus. The fetal echo was challenging due to maternal size and fetal position, but was suspected to have double outlet right ventricle with a subaortic VSD and a subpulmonic conus. There was cardiac malposition due to left lung hypoplasia, and a fetal MRI was ordered to assess the lung volumes. And so we piggybacked on that to do a fetal cardiac MRI to try and figure out the anatomy a little bit better. And I will say this was our first proper fetal cardiac MRI. And so the fetal MRI was truncated. They did very limited sequences to try and shorten the time so that we could focus more on the heart. The MRI protocol that we use, this is courtesy of Northh Medical. We have the exam card, as you can see here. So maternal survey, single shot imaging in all 3 fetal planes, and then cine imaging in all 3 fetal planes. We did try the 4D flow as well. Thus far, we've not been too successful with the 4D flow. So that is definitely the aspect that we would love some help or guidance with as we live scan. So we get our survey first. I'll play this first, and then I can slow it down. I have the parameters here. The TR was 2.9. The echo time was 1.45. And then just to show on the survey, as we all probably do, you can see that the transducer is right here, which we thought was the best location. You could maybe argue here might be closer to the heart. But if you will notice, this is the spine here, and already the heart position is really, really weird. So this is the spine here, this is the left ventricle, this is the right ventricle. And so the orientation of the heart is very unusual. But this is mainly just to show that the transducer was here, and we got, for the most part, a very reliable signal for about 30 minutes of this scan before it started becoming unreliable. But then we were a little bit too far into the scan, and we didn't want to push our luck with repositioning it. Then we go into our single shots. TR was 3.62, echo time 1.81, and a slice thickness of 5 millimeters. I put this in here just to show the fetal movement that we were experiencing. You can see the abdomen moving all over the place. This was with the maternal breath holding, and the fetal motion, and sort of the graininess of it as well. So because of that, and we did that in multiple planes, coronal, sagittal, and tried to improve the image quality. Because of that, we switched to a compressed sense BTFE multi-slice single shot. Here are the parameters here. This first sequence was a slice thickness of 6 millimeters. The compressed sense factor was 2.6. And we felt that the images were a little bit better with this, so we stuck with this for the remainder of the scan. And so as I play this here, again, so we're going to see that the spine is back here, and the heart is displaced into the left chest. This is the left, this is the right, and this is the left ventricle. Again, that left ventricle is oriented sort of towards the spine. This is the apex of the left ventricle. The right ventricle is here. This is the front of the baby. The orientation of the heart is just very unusual. And we're also starting to see great vessels coming off. And we do confirm that there was double outlet right ventricle. Some of the other images will show it better, but both great vessels come off the right ventricle. versus the left ventricle. And then we got the using the same sequence in the sagittal plane with parameters. Here we went down to 5 millimeters thick. Here we see the left ventricle, and realizing this is the superior portion of the left chest and the orientation of the left ventricle, the right ventricle that's larger. We see that a ductal arch right here. And then we're also seeing that there's 2 outflows coming out of that right ventricle with a subpulmonic, with some flow acceleration and subpulmonic conus. Good function that we see both on the left and the right. And then the last image here in the coronal plane, left is going to be over here. So the heart is in the left chest, and then this really just shows nicely, again, that unusual orientation of the ventricles in the superior portion of the left chest, which was very unusual. And I should mention prior to this, as I mentioned, the fetal MRI scan was done for lung volumes, and that was obtained prior to this. So we had some black blood imaging, some TSE imaging as well that I won't show just in the interest of time. And then this is also showing that here's your right main stem, and the left main stem was very hypoplastic, in keeping with the diagnosis of this patient, which from the fetal cardiac MRI in the setting of the left lung hypoplasia and the very, very small left main stem bronchus, we thought this was topsy-turvy heart. I've seen a lot of upstairs, downstairs, crisscross, all kinds of things. I've never seen a topsy-turvy heart. The clockwise rotation around the heart's long axis with the superior-inferior relationship of the ventricles, and then the displacement of the great arteries inferiorly and posteriorly combined with the tracheobronchial abnormalities is what makes this topsy-turvy. It very much impacted counseling. Just from the standpoint of the malposition, the surgeons can only really do good surgeries if they have good access, and it's really unclear how well they're going to be able to access this heart from sternotomy. And so the discussion of 1 ventricle versus 2 ventricle repair as it relates to surgical access, it's still in question, but it allowed for appropriate counseling of the family. Postnatal imaging, here's the CT on the left. See, I'll let this play through real quick and then I'll slow it down. CT on the left here, and here again you see this unusual orientation of the heart pointing towards the spine. So your left ventricle is here, your right ventricle is here. Apex of the heart is right there. It's pointed posteriorly, and then coming from this right ventricle, there's 1 great vessel, which is your aorta. And then your second great vessel right here, which is your pulmonary, a very hypoplastic left pulmonary artery right there, and then a normal RPA you're going to see right there. And then this is the ductal connection between the transverse arch and the RPA. And I mention that only because that is what we did from a palliation standpoint. Underwent a PDA stent for stable pulmonary blood flow. And the plan is for likely Glenn at 6 months of age, but we'll probably print a model and see about whether or not a biventricular repair is possible. And this is just the 3D reconstruction of how the heart lays in the chest. And there's sort of posterior and inferior displacement of the great vessels. And then you can see the ventricles as well and their unusual orientation. This is the apex of the left ventricle. This is the apex of the right ventricle pointing up in the left chest. Essentially in the left armpit. So echo scanning postnatal for this baby was remarkably creative for our sonographers. So moving forward, the more scans that we can do, the better. I do want to just do dedicated fetal cardiac MRI scans, not on the back end of fetal MRI scans, just from a length of study. And And then obviously in the US, I'm not sure how it is in Europe, but in the US, billing is an issue. I'm not aware that we're billing yet for fetal cardiac MRI specifically. I'd be interested to hear from other folks in the US if they're able to. But once that happens, I think it will explode with respect to getting these studies. And that's all I have. I want to thank my fetal MRI imaging team, Jen Cusero, who's our fetal radiologist, who we do the studies together, and then my imaging team, Zach Barr, Linda Ram, and John Pinheiro. Thank you.
Thank you so much, Peace. Regarding reimbursement, let me just mention, yeah, thank you. Now Eleanor is raising her hand, and I wanted just to raise that. Eleanor, just yeah, I would like to let you speak. Can you do it on your own, or do I need to empower?
I think I am unmuted. Can you hear me okay?
Yes, we can.
Hello. Hi, Peace. I'm Eleanor Schuchart. I'm at University of California, San Diego, and Rady Children's Hospital. I am working on putting together an application for the creation of a CPT code specific to cardiac fetal CMR. Currently with my clinical cases, I've just been using the only CPT code there is for fetal MRI. But that does make it challenging to share billing with our radiologists and to really have fair reimbursement for the time spent in cardiac imaging. So I'll put my email address in the chat and anyone can reach out to me. I think that we should utilize our professional societies such as SCMR to back the application because as I'm learning about this process, it usually takes about 2 years.
Yeah. That was great. Thank you, Eleanor.
Thank you, Eleanor. Just a short question piece from the audience. Were the lungs, regarding your case, were the lungs and the diaphragm normal in your case?
Yes, they were. Well, the diaphragm was normal. The lungs were normal, but the left upper lobe is completely absent. And the left upper lobe bronchus is absent as well as the left upper lobe, the left upper pulmonary vein. So that left upper lobe just never formed, and is I'm sure the reason that the heart shifted into that location.
All right.
Thanks so much.
Great. Thanks so much.
We are now already a little bit late, but we will of course continue, and we hope that you all stay with us for the little bit extension because we have very interesting discussions and cases, and we don't want to interrupt this. So apologies that this will be a little bit longer than expected, but we also hope that this will be very interesting for you, and that's what it's for. Regarding the billing from the US, I also have one comment because Lorna Brown from Denver, I was also talking with her about it. They also use the fetal MR code, as Mansi also said that in the chat. And under certain requirements, this is applicable and they use it, and Mansi as well. So I think how to use this and what kind of requirements to meet would be really interesting. And we will research this, and once we have it, what requirements, how to do it, we will share it with the community.
Great. And also again, as information for all of you, we will record this meeting and we will send it to you, the link for the recording. So in case you need to leave earlier, it's not such a big problem. All right, and with that, let's go to our next expert, which is Eilish Sira Hanai from University Clinics in Heidelberg. And Eilish, great that you're here. Yeah, and I can see your slides already. Perfect. Eilish, sorry, you're still muted. Please, you need to unmute yourself. No, I can't hear you. Oh.
No, cannot hear you.
Maybe you have to change your input for the audio.
Was working before.
Now we hear you.
Now
Perfect.
you hear. Yeah, great. Perfect. All right. Oh, now you're gone again. So it might be something when you had it up. No, you're gone.
No?
Yeah,
Is
now
it
I can.
better?
Yeah,
Yeah? Can you hear me now?
yeah, I can hear you.
Okay, brilliant. Brilliant, great. Hi everyone, my name is Eilish Hanai. If you lose my microphone again, just let me know. I'm from University Hospital Heidelberg. I'm a doctor in training in cardiology, specializing on cardiac imaging, and our program in fetal CMR is also still quite new. We're still developing it, but we actually perform solely fetal cardiac MRI. So we really take just sequences for the heart. And so as I said, we haven't performed a huge number of exams, but I just want to present one case that really changed clinical management for the patient. I have no disclosures. This was a 36-year-old healthy patient. It was her 4th pregnancy. She'd had 3 miscarriages before. And this patient presented to her local gynecologist, who also specializes in fetal echocardiography. And both he and his colleague were not able to visualize the aorta, the aortic arch, and the descending aorta in what would be called the 3-vessel trachea view, as you can see here at the bottom of the slide. So the patient was referred to our specialized fetal echocardiography lab here at the University Hospital Heidelberg, and image quality was reduced. The patient was overweight. So 2 of our very experienced examiners also were unsuccessful in visualizing the aorta and the aortic arch. So the patient was referred to our department for cardiac imaging with the suspected diagnosis of anomaly of the aortic arch. Specifically, our colleague suspected interrupted aortic arch, which would have meant that the infant would have gotten an infusion in prostaglandin after birth. So I will just walk you through our images. Can you see the MRI images now? Ida?
Yes, we can see them.
Okay. Okay,
Yeah.
brilliant. So it worked. Okay, great. So we have a 1.5 and a 3 Tesla Philips scanner, 2 scanners here, dedicated for cardiac imaging. And this was performed at a 3 Tesla scanner. As you can see, we don't have a huge number of sequences, even though our patient was in the scanner for 50 minutes. And that was due to a few technical issues. We lost the signal a few times. We had to reposition the transducer a few times. So that created a few pauses and just took a bit of time then. And I'll just walk you through the protocol that we use. We also use the protocol provided by Northh Medical. So we start with a maternal survey. As you can see, the fetus is well visualized. We then continue with T2 weighted TSE imaging in different planes. With these 3 here. We then continued in this case also with the single shot BTFE imaging, different planes as well here. And after this BTFE imaging, we had to reposition the transducer again. And after repositioning, we decided to repeat the T2 weighted imaging because we felt that that was really the sequence that answered our question to this exam. This is what, for some reason, this was sequence 7. And then after repeating the TSE imaging, we performed real-time imaging and then a cine image in 2-chamber view. We would have continued with some more cine imaging had the patient not wished to discontinue the exam. She was feeling quite uncomfortable, which is understandable also after 50 minutes in the scanner. So we'll just look at this sequence. As I said, we felt this was the sequence that really answered our question. So obviously we're interested in the aorta, the anatomy of the aorta in this case, and we'll just continue, we'll just follow the aorta, descending thoracic aorta here, continue heart left to right, continue upwards, and we have the aorta here, keeping it here, and then we have this image which basically answered the question for us. We have the aortic arch going into the descending aorta, the superior vena cava, the pulmonary artery, and the ductus going into the descending aorta. Also here from left to right. So this confirmed diagnosis of a right-sided aortic arch. And I just want to point out at this stage that our fetal CMR program is very interdisciplinary. As I said, I'm from adult cardiology, focusing on or specializing in cardiac imaging. We have colleagues from fetal echocardiography as part of the team, and we have pediatric cardiologists present. And also while doing these exams and while having the patient in the scanner, there's my colleague, Professor Alexander Kovacevic from pediatric cardiology. He was present while we were performing this exam, and Dr. Florian Andre, who is head of cardiac imaging in adult cardiology. So we really analyzed these images together. And this was the image where Alexander said, this is the image that answers the question for us. This is the typical image that you would also see on fetal echocardiography, a kind of U shape of the pulmonary artery, the ductus, and the aortic arch with the superior vena cava up here. So right-sided aortic arch. I am just going to go back to my presentation so we can see, sorry, this would be the corresponding image on fetal echocardiography had we been able to obtain these images. Also here, the kind of typical U shape of the ductus going into the descending aorta and the superior vena cava that we see here. Right, so we really got a diagnosis from fetal CMR, right-sided aortic arch, and further clinical course of this patient 3 weeks after performing our CMR, which we had performed in gestational week 32 plus 4. The patient presented due to severe preeclampsia, and an emergency delivery was performed at our hospital. And right-sided aortic arch was then confirmed on echocardiography after delivery, and the baby and the infant and the mother were discharged home after about 10 days. The mother and the father were instructed to be vigilant of any symptoms that may be indicative of complications of right-sided aortic arch, which would be difficulty swallowing, stridor, or frequent chest infections. The baby was, the infant was asymptomatic after birth, and as of now is doing very well and is asymptomatic. Yeah, so fetal CMR provided valuable information for us in this case, and it really changed clinical management for this patient. So we were very excited to have seen this patient, and I just want to show you a picture here of our fetal CMR group and program. This is Dr. Henning Steen, Dr. Florian Andre from adult cardiology, from cardiac imaging. Daniel Asmussen is head of the technician team. Professor Gorenflo and Professor Alexander Kovacevic are from pediatric cardiology. This is Dr. Michael Elsässer from fetal echocardiography, so from gynecology, and this is myself. So it's a very interdisciplinary matter, and it's very rewarding working together in this team, and we're very excited to scan more patients in the future. Thank you very much.
Great. Thank you so much, Eilish. I think the last point that you mentioned, beside the very interesting case, is very, very important to have an interdisciplinary team and a good cooperation inside the team. And then that's a need for implementation of fetal CMR workflow in the clinics. That's what we have learned. We will jump, Eilish, directly to the next, to our last speaker today. And yeah, the image, as I said, is missing. However, this doesn't matter. You will see now Christopher Hart from University Clinics in Bonn, in Germany. And yes, you can start, Chris. Happy to have you here.
So hello to everyone. I hope you can see me, and can you see my screen? Is it shared?
Both successful, yes. Mm-hmm.
Okay, very good. So I'm going to talk about a fetal cardiac MRI and complex congenital heart disease, a clinical case. I'm a pediatric cardiologist, nothing to disclose. And we started our fetal cardiac MR service in 2021. We have so far ended up about 100 cases. We work on a 3 Tesla Elition X Philips scanner with the spine and anterior coil, nothing special. We usually perform our scans in the 30 to 36 gestational week. We don't use any sedation, neither on child or on mother. And of course, we use the ultrasound gating. This is some kind of our protocol. We start up with a survey to get an idea of the fetal position and especially the fetal position of the fetal's heart. And after this first survey, or even after the first single shots, we try to place the transducer in the right position so we have the best acoustic window. And afterwards, we repeat the survey to confirm the correct position. And we start out with single shots, balanced SSFP CNAs, and we try to do some 40 flow. The balanced SSFP CNA is our working horse, and we try to get the best of it in every scan. In this case, this is a case of a fetus with absent pulmonary valve. This is an extreme form of tetralogy of Fallot. It shows severe stenosis and regurgitation of the pulmonary valve due to a pinhole-like pulmonary valve. It ends up in giant pulmonary arteries, compressing both lungs. And in this case, we had an absent arterial duct was good for the fetus. And we had, due to compression, alterations of left and right lower lobes. So I will show you some images. As I mentioned, we start up with the first survey and with the first SSFPs to get an idea where the heart is and where we can place the ultrasound transducer. The first single shots, the first black bloods that we used, they are aligned to the mother. You can see this is the belly button, so we have an orientation to place the transducer on the mother's belly. And afterwards, this is the second survey. You can see we place the transducer over here, and we have the heart of the fetus right here. So it's a good position. Even in this second single shot, black bloods, they are orientated to the fetus. You see, this is the transducer, and here in the best acoustic window, we have the heart of the fetus. So this is our idea of getting best signal throughout the long scan. Okay, first try in this case, CNA imaging. you get an idea of enlarged left pulmonary artery, but you see blurry images due to mother's movement, breathing, breath hold wasn't possible, and of course we had movement in the child, in the fetus. So what we did as a next attempt, we tried to do it without breath holding. We had 2 repetitions in the scan, and we got pretty good ideas of the ventricles. We have an enlarged right ventricle here. This is orientation. This is, of course, left side, and this is right side. We have the descending aorta. You see alterations in the lower lobes of the lungs, both sides. And we come to the VSD here. It's malalignment VSD. And already you can see that we have this here, over here, this tumorous mass. This is the left pulmonary artery. We have the aortic valve over here. And this is the pulmonary valve, or let's better say, this is the position of the pulmonary valve. It's the absent pulmonary valve, the pinhole, and you see the jet turbulence over here for the systolic. This is the systolic image here, and the diastolic image over here. So you see we have severe stenosis and regurgitation in this child. Again, pulmonary artery enormously enlarged over here. This is the aortic arch crossing over here, and the head vessels over here. So we could confirm the diagnosis, and we went on in the scan. This is what we get right of it from the first 40 flow imaging. We have a maximum intensity projection of the velocities in the scan. So that was quite good quality, and afterwards we repeated scene imaging, this time in coronal orientation, and you can see here this is the aortic arch over here, ascending aorta, and right next to it this is the left pulmonary artery, enormously enlarged and compressing the left lung, and over here right lung. So we thought that this would be a poor prognosis about adaptation after delivery, and so we consulted our neonatal colleagues that there would be probably the need of mechanical ventilation right after birth. I showed you some images of the 40 flow. This is afterwards, of course, the reconstruction. I'm sorry. So I want to show the thing moving. You can see this is the aortic, the ascending aorta and aortic arch over here, and you have an AP view onto this enormously enlarged left main pulmonary artery and left pulmonary artery. You have regurgitation of the pulmonary valve over here, and this is the right ventricle in the front. The other image over here, you get the same idea from a sagittal view from the left side. In the front, the right ventricle, this is the left ventricle. You get the pulmonary valve over here, the pinhole-like one, and then you get these turbulences and vortex flow in the left pulmonary artery, showing the mechanism of the enlargement of the left pulmonary artery due to the wall shear stress that is happening in the left pulmonary artery due to the jet from the pinhole-like pulmonary valve. Again, aortic arch over here. This just adds to the understanding of the problem of the child. I go back to my presentation. Very interesting. We still need postnatal imaging. So I show you the images afterwards, after delivery. And the child told us wrong. It did not need any mechanical ventilation and was showed a quite good adaptation in the first few days of life. But you can see this is the enlarged left pulmonary artery here on X-ray. And in our first CT scan, that was a few days after delivery due to deterioration of the respiratory situation. You see in the CT scan pulmonary valve here, pinhole-like, the enormously enlarged left pulmonary artery and main stem, and the right pulmonary artery here. In the basal lower parts of the lower lobes, we have this formation here in the lungs. And of course, the VSD, malalignment VSD, you remember it's an extreme form of tetralogy of Fallot. And afterwards, this is the aortic arch. And we have compression of airway, especially on the left side, but also on the right side, due to those tremendously enlarged pulmonary arteries. Perhaps you remember the coronal view of the fetal cardiac MRI. This looks pretty much the same. This is the enlarged left pulmonary artery, aortic arch, and ascending aorta here. Just to show you that we see the same things prenatally and postnatally. This is, again, airway compression here. The child had an operation, the tetralogy of Fallot was corrected, and the pulmonary arteries were minimized. The enlargement was minimized. There was a lot of material cut out. You see there's less left pulmonary artery here. This is the X-ray directly after operation. And a CT scan that was performed due to the suspected airway compression showed one operation technique. This is Lecomte maneuver to get rid of airway compression here in the back by those still enlarged pulmonary arteries. And you can see nicely that here airway, there's no longer airway compression on the left or right side. But still we have problems in the lungs, of course, but VSD is closed, so we had a good post-operative course. And this is the same view, coronal view. You see still enlarged, but less smaller than it used to be. This is the right pulmonary artery over here. And you see less airway compression, especially to the left side over here. So this is my clinical presentation of this case. And of course, the Doppler ultrasound for cardiac gating enables us to have fetal cardiac MRI within a clinical setting. We have scans and sequences that we can have a look at right while we are scanning and react on what we see. And I think we are on the best way to expand the application and allow a better prediction of postnatal outcome and adaptation. So thanks a lot. And I just have an image here. You see what our fetuses think of our cardiac fetal MRI program. Yeah. Thanks a lot for your attention.
Beautiful image.
Yeah, thanks a lot, Chris. I would like to ask Chris. You have shown so very beautiful 40 flow images, and you have a really large number of cases, fetal cardiac cases already scanned. And how many of those cases about do you perform fetal 40 flow successfully, and in how many of those cases are they, or the result, usable for clinical diagnosis? Can you comment on that?
Yes, of course. Thanks a lot for your question. We try to do it in every case because it's a sequence you don't need any planning for. You try to get a feel of view about the whole thorax, and you go for it. You have to be in the golden window, so the fetus has to lay still, and you keep fingers crossed not to get too much fetal motion. And we have a very highly accelerated 40 flow that's about 6 to 8-fold acceleration, compressed sense. And we try to perform the 40 flow. You have to be quick. That's the idea, our best idea, and we get best results if we are quick. So we try to keep in the time of 2 to 3 minutes. And now, of course, it does not work always, but we're on a good way, and we try to get additional information of hemodynamics. For example, the flow in the duct or the flow in the aortic arch, especially.
Thank you, Chris. Peace was mentioning before that he is also very interested in 40 flow, and maybe we can, like, for all of you that are interested, maybe you can just send me an email or also comment here. So I have an idea about who is really, or who are really the people who are interested, and then we can maybe pick it up for the next webinar session or something like that. Okay.
I also have one question, and then I think we should close. But one, because you have 100 patients already scanned, and for some hospitals, I think it's very interesting to understand how the referral process works in your case, that you have such a high number of cases. Can you explain a little bit how you do it?
Yes, of course. Thank you again. And we were very, very close together with our obstetric team, and they are really interested. This is good luck for us. They are really interested in fetal cardiac imaging, and especially in fetal cardiac MRI. They just want or they think fetal cardiac MRI is a possibility to confirm their echocardiographic diagnosis. Yeah, so if we have like an adult grown up and we go for an operation, we do a CT scan, we do a cath, we do an MRI, but in our fetal cohort, we just go for ultrasound. So I think that's not fair. So that's their opinion too. And they want to have their diagnosis confirmed by fetal cardiac MRI. That's why we do not have any problems with referral of cases.
Oh, great. Okay, thanks so much. That's a good explanation that I actually like.
Yeah, I think the cardiac MRI has especially very good quality when we talk about the great vessels, the lungs, and the position of the heart. For example, in very complex cases like heterotaxia or something like that, there see the really best efforts we can do.
Yeah, thank you so much.
Yeah, thanks to all of you. I think this was a very, very interesting session with very interesting cases and good discussion. So that's exactly what we want to keep also. Thank you very much to all of the speakers, to the whole audience, to your questions, to the discussions. That was great and a lot of fun. I think there's a long way before us that we can go. Yeah, with that, I would like to close. For those who would like to stay in the meeting, so I won't leave the meetings. The meeting will be running, so you can, if you want, discuss if there's someone. Yeah, I thank you for your support and attendance. And as I already told you, we have the next session, the summer session in June 12th, and I'm looking forward to that and to see you there. Thank you so much.
Thank you, everyone, especially to the speakers.
Thank you. Bye-bye.